I've entitled this AI in Action because I'm going to talk about the AI on the ground that I've been involved in. So first of all, here's a picture of one of my former doctors who used to work for me. His name's Dr. Rizwan Malik, and he is the only person outside the US to win an AI Med Award. He's a radiologist, and he is somebody that spent a long time studying algorithms for radiology. I just put his Twitter handle there because it's worth you following him. For me, he typifies what is the sort of coming wave of people who balance the risks and opportunities within healthcare. And his background is chest reporting. What is wonderful about Dr. Malik is that he has spent time putting in place governance, controls, and other balances to make sure that we're working at the frontiers of science, which is what our NHS constitution says we should do. So what we really see is that we're seeing algorithms being used in radiology and digital cellular pathology, in particular to identify images that would have a diagnosis that need to be reported. We're seeing risk stratification being used on pathways. Now, I have personally been involved in risk stratification for kidney disease, for delirium, for dementia, for sepsis. But what we're doing there is using algorithms to try and work out who is going to be most susceptible to conditions. Some people include RPA in AI. We're using that a lot more to make sure that data moves between legacy systems. If you think about COVID, we've had a backlog. We need to move people into referrals. We've got data science platforms which are enabling data scientists now working within healthcare, and we're producing several hundred of those a year in the NHS to actually be able to provide insights and actually find areas of improvement. And robotics is increasing. We're using autonomous telehealth robots. We've always, used some robotics in pharmacy. That is growing. And so our confidence in robotics is new. But you will see, actually, that this surprised me the first time, self-driving robots walking around certain hospitals for telehealth. They'll direct themselves to the beds. And actually, I think it was the first time I found a robot unsupervised that I really realized that robotics was happening for real. Now, we've talked about all of that, but actually I sit on the AI Council for the UK government, and my job is not to talk about all of these wonderful blue sky things. It's to talk about how we do this at scale and pace safely. And actually, the AI Council is made up of multiple industries. It's made up of nuclear industry, aviation, retail. And I found that incredibly useful because I've worked with, in particular, those three industries on creating a life cycle management regime for AI. And really, my analogy for this when I'm working with senior leaders is it's a bit like having a junior doctor or a nurse. You need to be able to manage their performance, audit them, train them, see if they have some bias in how they're operating. And to automate that and manage any exceptions is really important. So I've worked with those other industries on transparency. This isn't about what we heard this morning, which is the initial validation that's done by the MHRA. This is as things change, as we keep it in operation, how do we make sure nothing goes off? And it includes things like bias in data and training for new data sets it may run over. The other very interesting thing about governance is to work out where we use AI. And there are so many opportunities for deciding what we do. How do you work out where the right use cases are and the right opportunities are? And how do we also work out where we develop with our data scientists, where we can buy from the market because it's ready, where we partner? And what has become very important with this is the work I do in the academy. And the academy is 125 C-suite level healthcare leaders going through an MSc in digital health leadership. And as part of that, we teach them how to be the intelligent client for AI and advanced technologies, how to understand which use cases to actually pursue, and how to decide where you build, buy, or partner. The final thing I'd really like to talk about is data. And data is absolutely key for AI, automation, increased intelligence. And I use the word increased intelligence because not everyone agrees what AI is as a definition. Just so you know, our UK AI Council, reporting into our government, had a lively 30-minute debate between itself around what AI was and didn't agree. So even the experts don't agree. So I say increasing intelligence, but if we're going to do increasing intelligence within our organizations, then we need clean, codified, real-time data that we can rely on. And the biggest issue we actually have in our healthcare system at the moment is moving towards that data, because what you feed your AI really defines the quality. Here's a picture of another one of the wonderful clinicians that work for me. In this case, an anaesthetist who also trained in data science. And the lovely story here is that as we get our clinicians, more interested in this and understanding, they also help to improve the data. So that really is a whistle-stop tour of what's happening both in my previous organizations where I've been a CIO and also the UK. And it gives some hope that we can do what it does say in the NHS Constitution, which is to work at the frontiers of science with world-leading skills. So thank you. And they're the Twitter handles for myself and the organizations I represent.
Thank you very much. Thank you, Rachel. Thank you very much. By the way, you saved time, which is very nice. By the way, the techniques, please put the counter on the other screen for the presenter. So Jorge, please. So, thank you very much, Rachel. So Jorge, now you will take the floor. Jorge Juan Fernández García is the Director of Innovation for the EIT Health. EIT stands for European Institute of Technology. So it's an initiative that Europe launched a few years ago, but you will explain that to us. Previously, you know very well Barcelona because you live there. You've been as well working as a Director of eHealth for an hospital, a public hospital here. So you have been director of Mebio as well, the initiative for startups here. You're mentoring startup, so you know very well the environment we have here in 4 years from now. And so you will explain us from the EIT Health point of view, what are the upcoming challenges on AI. Please, Jorge.
Very good. Thank you very much. Hi, everybody, and thank you again for the invitation. EIT Health stands for European Institute of Innovation and Technology. Just not technology. Technology is a means towards innovation. Innovation is the impact that we want to see in healthcare. Okay. EIT Health is a network of the top 150 institutions and companies in Europe, more than 40 medtech, pharma, digital health companies, more than 300 healthcare providers, payers, patient associations, and we also support more than 800 startups. So, you know, we know very well the ecosystem in healthcare across Europe, right? And one of the most important items that we worked on in the last year is around the topic of AI, artificial intelligence. We decided to launch a report again with McKinsey and the McKinsey Global Institute. We published it on March 2020, so it was the last event in person that we did. So it was the same week that we went to the lockdown, let's say. And our idea when we did this report was that there was a lot of people talking about AI as a technology, very much the focus of the conference here. A lot of people talking about AI as a potential business. A lot of people, especially in the European Union, talking about the ethical implications of that, say the GDPR and the different things. But we thought that there was a conversation missing here, and the conversation was around what is the impact of this technology on healthcare professionals and in organizations, because these are the people that will be using healthcare and they will be the ones using that with patients, right? So that's these two reports. We have updated that on March 2021 with the views of all our community. And I want to share with you the main key findings, right? So I'm just going to spare you the 110 pages of the report, okay? So the first one is, how will AI impact the workforce? So we have identified, after thorough analysis, mathematical analysis with McKinsey Global Institute, the following items. The first is that the AI solutions will destroy activities and tasks more than they will make jobs disappear. That's very important. In healthcare, almost every doctor is afraid that my job, will disappear, specifically certain specialties. Radiologists, being the first one, dermatologists, and others, right? So the first thing is it will destroy activities, but not jobs. The second, some are more important impacted than others, of course. Those in diagnostics processes where biomedical imaging is important, where data is, significantly available. Those will have more impact, and those, where the hands are more relevant, let's say, there will be less impact. It will not the good ones, the good use of AI will not substitute them, but will augment it, and that's where we will see the good uses of AI, and that's really the challenge out there. Will people use it to replace people, or will people use it to augment the capabilities of different people? And then the last one is, and that's very important, people will need to be reskilled, right? So, this is people think that we will be able to put these technologies in the hands of professionals and patients, and then the magic will happen. Very far from the truth. We will need to reskill people. We will need to develop a new humans, and machines value equation, and that's something that everybody needs to work on that, right? And then in terms of the organizational model, we've seen a lot of people talking about the three potential models, and the first one is fully decentralized, meaning that very much the model that we followed here in Spain around the EHR, the electronic health record. So everybody does his business, and then it's really difficult to make any connections and any smart sharing of information. On the other extreme, fully centralized national health systems or regional health systems, taking the lead. That was something of the past. Nothing happens again. So we are seeing more and more people going towards a mixed model on that end. So these are the key findings. You'll find lots of data in the report if you're interested, and lots of graphs for your presentations as well. And then I want to bring the attention to everybody on so there's two big issues around AI in healthcare. The first one, of course, as I said, is this new value proposition for the technology, the humans, let's say, and the machines, right? And then the second is this idea that software is eating the world. It's going to be, soon it's going to be 10 years since Mark Andreessen published the op-ed in the Wall Street Journal. It was called Why Software is Eating the World, right? And then basically his idea is that, in the next decade, software, and so every company will become a software company, everything will be software. And we've seen lots of these things in different industries, very common, for example, financial services, commerce, and other things, right? But when we take a look at healthcare, and there's people also making this, this typical thing. If software is eating the world, AI is also eating software, right? But when we take a look at healthcare, this is more words than reality, right? So you see this, but then on the other end, when you talk to people in the clinical settings, this is not really happening. So what is that? And I think this is the next conversations that we need to have. Why things are not happening the way we want. And then, so basically two things here. Let's say the first one, why is that? Because from industries are different, and they're different because of two things. First is the amount of regulation available there. Healthcare, we have lots of regulation, and it's different between countries, and that makes it difficult. Then on top of that, we have the new regulations, MDR, coming in place, a lot of uncertainty for startups on that one, right? And then the second one is tangibility. This idea that for some things that are more tangible, heavily tangible, it becomes more difficult to digest, right? So the idea is that software, or let's say industries, they need this software, these digestive pills, to be able to make sure that AI eats software, or let's say AI eats the world, let's say, right? And my question to you in the last 3 minutes is, what are the three biggest digestive pills that we can use in order to accelerate implementation of healthcare in our industries, right? So first one, very, very clear. The legacy systems, the same, IT legacy systems in hospitals are a problem. Electronic health records is probably the most hated piece of software in the world, let's say. I still have to find one doctor who says, I like my my electronic health record. It's just impossible to find. It's a miracle, right? It's usually the most important part of the IT budget, and then the big problem usually is that hospitals do not have enough time to replace their old system. So we need to do something so we can really transform those IT legacy systems. That would be the first digestive pill. The second one would be we need to increase the budgets for IT, right? So basically most hospitals and most clinical settings all they manage to do with their IT budget is to pay the electronic health record, and that's it, let's say. So the difficulty is there. Basically, these days, across Europe, they're spending between 1% to 2% of their full budget, right? That's not enough. What we know from other industries is that higher percentages of budget is needed, for the real breakthrough to happen. So we need to increase budget here. That's another challenge, right? And then the last one, very important, there is a talent shortage, right? So it gets really, really difficult on one end, let's say, to get people to be attracted to healthcare and hospitals, right? They're not the most attractive places. Pharma are becoming more and more attractive to people. Let's say the main problem pharma companies, they're good places to work, so they have low attrition rates. So it's really difficult to engage, to substitute, let's say, the profiles that are less relevant in pharma for the profiles that will be more relevant in the future, right? And then the last one, of course, is that there will be this real need for training, reskilling and upskilling, right? So providing people with new skills that they don't currently have to do their jobs, and then bringing people from other industries to healthcare to do this, to apply AI in healthcare, right? So with these three things, I want to stop here, and it just make you think. If you have any other digestive pills in your minds, happy to talk about them in the Q&A. Thank you very much.
Thank you very much. Thank you very much, Jorge. We'll take questions afterwards, so start to think about your questions for the panel. So Gemma join us now to present. So Gemma Galdon Clavell is founder and CEO of the company Eticas. Gemma is a very well-known expert on the question of ethics on data-intensive technology companies. She's supporting different companies in different sectors, actually, not only in healthcare. But today you will talk about your work in healthcare, used by different companies. We have the chance to have in our community. That's how we know each other, actually. Gemma will present us work on the concrete application, concrete launch of ethics and trustworthiness inside the technology and digital health. Thank you, Gemma, to be here.
Thank you, Julian. Thanks for the invitation. And I'm very happy to share a panel with amazing speakers as well. I think it's working really well, and I hope that I can contribute to helping you understand how we work on the ethics of technology from a specific perspective. I'm especially grateful for the invitation because it's an invitation to talk about specific cases and use cases, which is something that I like to do a lot. Oftentimes, the ethics of technology sounds like this very abstract theme that no one really nails down or lands. That's not what we do. As Julian said, I lead Eticas, which is a leading organization globally on algorithmic auditing. Our mission is to protect people in technological processes, because everyone's thinking about the technology, and not a lot of people are thinking about the people and the data of the people that takes part in those technologies. So that's our mission. And we serve our mission through different means. One of them, our start service, is algorithmic auditing. Our first client in algorithmic auditing was actually a health-related client, a moonshot of Telefónica that has now gone independent, Coa Health, and we've been working with them for, I think, almost 4 years already. And over time, we've gained other clients also working in the health sector. Just to give you an idea of the things that we've done, we've worked on mobile wellness apps, on hospital risk assessments and hospital logistics to foresee how many beds you may need at any given time. Also in hospital diagnostics, as was mentioned by the previous speakers, and also in social services risk assessments. There's a lot of health issues that are being managed by social services, so to address the needs of the homeless population or of children that are at risk because of family context. So there's a lot of mental issues that are being dealt with in the public sector as well. And we just very recently, this week, we got a request to help an organization that is working on automating the diagnosis for eating disorders that has a really interesting problem that I'll mention. And I wanted to share with you in the little time that we have the 3 main findings that I think would be useful for an audience that works in health. The 3 main findings in the last 4 years of auditing algorithms. The first one is that auditing is an opportunity not only to address issues of bias, but also to address issues of inefficiency and to find many of the problems that permeate the way that we develop technology in the health sector. Jorge was mentioning how the legacy in IT is usually terrible. There are systems that don't interoperate. So actually auditing an algorithm is a possibility to bring in an external provider that can look at how things are integrating and how things are working. So it's like your additional layer of guarantee that things are working well, not only at the bias level. So for instance, when researchers found that the Apple Card was giving 10 times more credit to men than women, that's not only an issue of bias, it's also a bad business decision. So, and we keep seeing that. Oftentimes, we talk about bias if it was only about protecting the vulnerable, and it is, but it's also about making better decisions. So many algorithms out there are not making the best decisions because they have not been audited, and they've been developed by engineer-only teams that don't know anything about vulnerabilities and bias, and oftentimes don't know anything about medical issues, and that is something that we're also finding. So auditing as an opportunity to get a lot of things right, including bias. The second big finding is that oftentimes the principles of data protection and ethics are doing a disservice to actually fixing systems and protecting people in those systems. So one of the things that we found with Goa Health, one of our first client, was that the principle of data minimization hurts us as algorithmic auditors. If you don't collect sensible data about your users, we cannot protect them. If we don't know they're in your database, we cannot protect them. So the idea of data minimization in data protection, which is great, is only collect the data that you need. Well, if I want to protect women or specific vulnerable communities in a data set, I need to know that you're there. So now what we're developing with COA is a system by which sensible data is only collected for the purposes of auditing. So you collect the data, but only we as auditors have access to it to ensure that there's no bias. But you only collect the non-sensible data, and you train the algorithm only on that data. So we need a lot more innovation on how to ground these data protection principles that oftentimes are made thinking about the bigger picture and not actually addressing how technology works. So that's our second finding. Just because data protection says so doesn't mean that you can implement it in a responsible way. So there is a lot of scope for innovation in lending the principles of data protection. And the third big finding, the main finding, is that bias is not something that happens once. Bias is not something about historical bias in your database. We have 8 moments of bias throughout the life cycle of the algorithm, from its conception to its deployment or removal from the system. We work on selection bias, historical bias, model bias, representation bias, implementation bias, measurement bias, evaluation bias, and aggregation bias. That's the moments of vulnerability in terms of getting things wrong in your algorithm. Just to make it simpler, not 8, but 3. We have 3 big moments when we audit an algorithm. First, we look at how you translated a complex medical problem into data points. And that's a really complex thing. Just think of the case of Optum, a technology provider in the US that was providing algorithms to the hospital sector in the US to prioritize people in the emergency room. So an algorithm would say, you go to the emergency room, you need to be attended to immediately because you're in serious danger of dying, or you can wait for a couple of hours. So that was decided, that's being decided more and more by algorithms. When this algorithm was audited, auditors found that the algorithm had been trained on financial data. So the decision on the severity of your illness was based on how much it cost to heal people like you in the past, not on how seriously and urgently you needed medical care. That was done because financial data was the data they had available. Collecting medical data was harder. And so that's what they did. And for years, they were making medical decisions based on financial data. An audit had to come years later and find that out. They also found that in the years that it had been implemented in over 100 hospitals in the US, the algorithm had been discriminating against Black Americans because they're underrepresented in the databases because they usually go less to the doctor, and when they go to the doctor, less money is spent on them because of historical social trends. So all that had been learned by the algorithm, who learned the algorithm learned that it was okay, it was not only okay, but desirable to spend less money on the black population, which is completely unacceptable, but also wrong from a business perspective and from a medical perspective. But these are the inefficiencies that are built into algorithms unless we look at them from an external perspective that is multidisciplinary and that addresses all these moments of bias. So this first moment of addressing historical bias and selection bias is crucial. And we already find a lot of problems just in how algorithms are designed. So without even talking about how we clean the databases, just design. What data do you collect? What data do you use to train your algorithm? Here we already find a lot of problems. But then we also find problems in the model. In the way that we deal with the data in that model. To give you an example, the client we just got this week, they're studying eating disorders. And they're finding that they have a lot more data on women. However, their results are less precise on women than men. And they don't know why. So we're going to start working with them on how is this happening. We're lucky that they're a research team, and therefore they're caring about those things. But in a commercial setting, probably no one would have realized that that was an issue, that the decisions on women were less reliable than those on men. This only comes up once you look at an algorithm from an auditing perspective. So the model can also be sometimes the source of the problems that we identify. And just to finish, the third part that we audit, and I don't need to go into it at length because Jorge helped me a lot, is the implementation bias. The way algorithms are implemented at the moment is completely random. So a hospital or a research group may incorporate an algorithm and decide, so from now on, you use this algorithmic decision to make decisions, but they don't train people on how to use that algorithmic outcome. And so we see a lot of human bias being reintroduced into the system in this latter implementation stage because the workforce has not been taken into account and because clear guidelines as to what is the weight of the algorithmic decision in the decision-making process, they have not been defined. So we basically see a lot of problems and issues when we audit algorithms. The good news, they're all addressable. So these 8 points of bias can be addressed. But you probably need an outside team, a multidisciplinary team, to help you to bring the external knowledge that you know, but also to build the trust among customers and patients. There's a very recent study by KPMG that says that 30% of the population in the Western world is unwilling to trust AI systems. We are seeing more and more people rejecting AI diagnostics tools because they don't trust algorithms. We've seen demonstrations in the UK against algorithms. So unless we put more effort into rebuilding that trust, into explaining how algorithms work and saying that we've done our work in removing those biases and making sure that our algorithms work in a fair and efficient way, I fear that that 30% will increase in the future. Thank you.
Thank you. Thank you very much, Gemma. Thank you for all these insights and practical approach of the subject. It's true that sometimes we have theoretical speech around that. It's interesting to see how you work and how you support your clients. So we are now at the Q&A session. So anyone with a question? Yeah, we have here one, here another one. So please, here, another mic, please. You. Sorry, you can bring the mic here, please. Yeah, thank you. Here, just here, please.
Well, thanks to all of you for all this great information. Maybe a question that's going to be more for Rachel and Jorge. All the health systems at the moment, especially in the European Union, are completely split up. Everyone's going with his own system, his own database, let's say, to make it simple, even in hospitals. Do you see in the foreseeable future a possible system at a European Union level, meaning that we're talking about how AI will possibly help to make things easier for doctors and for everybody who's working in health? Is there something that will happen at a moment that will come from Europe directly?
Rachel?
Yeah, so that's a great question. And let me first look at the UK, where we're going to separate data from application and standardize it in healthcare. So there have been lots of policy papers, one last week. Within Europe, I think the European data space will converge towards data standards. The reason is that CIOs and health systems are already above cognitive load with data. If we now add Internet of Things, apps and wearables, we have another proliferation of data. I actually rang 10 CIOs at one point and I said, are you in control of all of your data and could you make it usable for every patient? They all said no. We have to reverse that situation to make the data clean, codified, real-time, and the entire longitudinal record available for every patient to be able to leverage this. And our job is to use that data to keep our patients' lives safe, because data does save lives and improve lives. And so policy-wise, I think both the European Union and the UK have recognized that data saves lives and they need to act. And Europe is talking about balancing GDPR, which incentivized us to lock everything away, to have a duty of care to make sure that data is available in a suitable format for care, and I welcome that.
So I see that it's on the table of the different people that I talk to. It's an important conversation. Before it was not, so that's an improvement, let's say. So 5 years ago, this was not. Keep in mind that Europe most likely is the best geography in terms of data sitting on a pile of very structured data. The quality is different, let's say, but at least this is something that China or the US doesn't have. So that's an asset that it's now recognized. That's the first thing. Second, you need to understand that the European Union does not have competencies on healthcare systems, let's say, right? In as much as they would love to, which they have done some stuff due to COVID, let's say, but it's for each country. So so there's things, the European data space, that's an improvement and other things, but I think we will need, at least for what I call these IT legacy systems difficulties and the data problems that the colleagues were mentioning, we will need like a next generation type of thing to move forward. Lots of money to try to bring this to the next stage, right? And that is not currently on the table, let's say.
I had an extended question for you, Gemma, on the same topic. If you look at US or China or other part of the world, do you see some companies having the same approach as your client COA, for instance? And COA, we know that they are active in US as well. Is it important for US markets?
Yeah, one of the interesting things that we're seeing is that Europe has led the way in regulating AI and creating standards for data protection, but it's the US that is innovating in actually creating a market of responsible innovation, which is very sad to us because we think that the ecosystem could emerge in Europe. But the series of investment rounds that they're managing to get in the US just don't exist in Europe. So I fear that the US will take the lead also in responsible and ethical innovation because they're seeing that there's a need to do things better, and they're seeing that ethics and bias issues allow you to look at lots of other things related to also efficiency and trust. So I would say that right now we work a lot more in the US and Latin America than we do in Europe, which is interesting and sad at the same time.
It's unexpected, actually, to see that.
Yeah.
Let's hear what evolved, but this kind of message in Brussels would be useful, I think. I'm sure you're carrying them. We had one here, please.
Hi, thank you very much for sharing your thoughts and ideas. It's very interesting. I have a couple of questions, but maybe also a comment. I think that there's still a barrier to go through. It's the natural language and clinical records. I guess there's a lot of data and information there that we still have to mine, and I guess that that's another step to go. But I have maybe one question for you two first, and then another for Gemma. How could we, since I come from a public hospital, how could we help public healthcare systems or public hospitals to redistribute budget and resources and become pioneers on the digital transformation, not only AI. AI is a part of the digital transformation, and I'm feeling that, or a sense that one of the main issues here is not investing more, but redistributing what we have already. And then the second question, if I make both of them at once, if AI, as it is now, has so many biases and it casts this shadow on if it's trustable or not. How reliable is it, and how can you measure it? How can you measure the reliability of an AI, and if it's worth to start implementing it right now, or maybe we should wait a little bit and see, well, now that it's 90% sure, 100% sure for the patients, then maybe we should start implementing it. Thank you.
Thank you. So perhaps on the first one, Rachel and Jorge, and then Gemma.
So I'll just make some comments about your last question first. The way forward that I have taken with that is to dual run an algorithm with a human process, and to use also the IHI quality improvement run chart methodology to prove that it is a quality improvement. Obviously still looking for bias for those groups, even if it does improve the overall outcome. Public hospitals spend, I think, and getting ready. Education is absolutely key. We need to change our workforces. We need digitally ready workforces, both in terms of those who will be the intelligent client and those who work in our organizations. And the benefits, you're right. Overall, this will take out waste, it will improve quality, and it will improve efficiency. And overall, the system should be able to reinvest. Very interesting case I worked on in Australia for a digitally enabled hospital with automation and AI. Overall, that took nearly 20% out of the entire health economy. So you're right there. We should be able to make this happen. It's pump priming it at the beginning that's the biggest issue.
Thank you.
I don't think the issue is to wait. I think it's more about changing the approach. So technology needs to be the answer to a question. And you need to start with a question. So you don't start by, oh, I have an algorithm, what can I do with it? But I have a problem, how can I solve it? And if an algorithm is part of that solution, then implement it. But I think you need to domesticate the algorithm in your surrounding. We see so many contexts where a CEO just bought an AI system, not thinking about what do I need, and then that becomes a problem. But so it's more about owning the process and understanding very well why you need that algorithm and how it works. I think that's the first thing that can be changed from a hospital perspective. But then we also need to change the industry. I think we need an algorithm development industry that is not focusing on selling the same thing to everyone. In AI, the secret of the value of AI is in customization. So if you have companies that want to sell the same algorithm to a hospital than to some kind of business initiative, then we have a problem. So I think we need to change the incentives of the AI developers, and they need to realize that the value and also the cost and the price comes with customization. And that means understanding your client. That means having doctors in your development team if your end user is a hospital. But at the moment, we don't have that. So what we see in our work are very much like very low quality AI that is being sold to everyone because everyone's looking to scale up and standardize. And in AI, you lose the value of AI when you do that, especially in high-risk environments like health.
Interesting. Jorge?
Very good. And then building on your idea, let's say, what can a public hospital do, right? So the first thing is you have to choose a problem, right? Don't come with a technology push, choose a problem. When choosing the problem, choose something that if you're successful in solving it, let's say, you will drive the change that you want to get. And that's difficult because most likely you will have some change agents or ambassadors or people willing to take the risk in different places, in different hospitals, right? And that's really difficult, right? But my suggestion would be don't try to think of I'm going to get one thing, one bullet that will solve everything, right? Just get something small, make sure that you get the things, test it, try to do some novelties, some good things, and then little by little, you will not change the world in one night, let's say, so, or in 1 year, let's say, so little by little. I think that's the best.
Thank you. Another question for our experts? No? I was keen to talk about a bit training and education around AI, and as well perhaps education on detection of bias you were talking about. I would have your experience, your vision as well for the future, what is missing, what experiences you have seen as a good practice or best practice. Can you tell me perhaps, Gemma?
Well, in our experience, when we work with technical teams, at our clients, they're really excited to learn what we bring to the table. So it's not like engineers don't want to know about these things. It's just they don't have the knowledge. They haven't been trained on these issues, and so they're not equipped to address these issues. But we always train the teams that we work with. So we want to make sure that in the future, Eticas is looking towards its own irrelevance in the market. We want to not be needed. We want algorithms to be of so much high quality that you don't need an external auditor. But right now you need it. But what we do is we train the teams and make sure that the next algorithm that they bring to us will be much better than the one we saw before. And so creating this kind of in-house knowledge and expertise, and also encourage our clients to bring on board social scientists and people that know about these issues from other perspectives that can also enrich and improve the way that they collect the data, they clean the data, and they build the model. So I see a lot of promise because there's no reluctance on technical teams once we start working on incorporating all these issues and they understand that they could be doing things better. So I'm hopeful in that respect.
Hopeful, good. Jorge.
So my experience, let's say, with working with startups directly is that I see two things. Just the first is the wording and the second is an insight. The first is that I find a lot of them that they say they do AI and they don't, right? And that's something for clients and people and that the line is difficult sometimes to see, okay? And then the second is sometimes what I find is not engineering problem, let's say, but a CEO problem, let's say. Basically, it's difficult to find some data sets that are, good enough to validate certain things. And then when you ask them, okay, you want to do something for, women, let's say, whatever, right? And you're building this on a data set that is 95% men. Don't you see any problem here? And there is always silence on the other end, right? So, and I think it has to do because it's difficult. It's easier to trick yourself than to do that. So I think we need to pay attention to also human biases at the top, let's say, not on the engineerings, let's say.
And what the CEO of the NHS Digital Academy is saying.
Yes, absolutely. I'm looking forward to
already.
the days when we do have algorithms that are really high quality, but they're not always, are they? And so for me, it's been around training doctors, nurses, clinicians, pharmacists in data science to postgraduate level, up to MSc level, so that they can move towards the algorithm and provide clinical safety assurance. They can ask the questions about how it operates and they can supervise it. And that is what we have had to do. We've had to push the clinicians towards the technology because the technology is not consistent. And that is something I'm pleased that we've done, but in the future I do hope that we will not have to do that and that these things will actually annotate what they're doing and how they work so that we can use them at scale and pace more safely.
Thank you very much on these hopeful messages. I think we can close the session. I think the technologists and in the room and in the Mobile World Congress will take this message to associate more and more interdisciplinary teams, medical teams, and social science teams as well. So it was a good message. Thank you very much to the three of you to participate and to join us. We can applaud the experts, please.